Mm-hmm. Go ahead, Liz.
Welcome to today's ASPPH Presents webinar, the latest in prepping public health students for obesity prevention and control. We're glad to have all of you with us here today. I'm going to walk through the method for submitting questions and comments on the next slide. We'd like to encourage everyone to step right in, and in the chat box there you can see the graphic here to join the conversation, the method for submitting questions, comments, ideas, any alternative viewpoints. We'd love to hear them. Just type them right in there into the box. All your lines are muted, and this is how you'll communicate with the organizers and the presenters on today's webinar. The Association of Schools and Programs of Public Health is really pleased to present this webinar on obesity prevention and control as a benefit to our member schools and programs. And we're also excited to have a couple of really interesting sponsors on with us today, the Interprofessional Education Collaborative, and as well the Milken Institute School of Public Health at the George Washington University's Summer M. Renstone Global Center for Prevention and Wellness is co-sponsoring. So I'm Liz Weiss, Director of Education at ASPPH. And I'd like to walk through a little bit of who this webinar is for and why. And our target audience primarily is the staff and the students at our Council on Education for Public Health accredited schools and programs. Secondarily, we're interested in, the primary is the faculty and staff, and our secondary audience is the students. Both of these groups focused on obesity prevention and control. And our objective today is, number one, to introduce the new obesity provider competencies to all of you, to give a few examples of what's going on at some interesting schools and programs on obesity prevention and control, and to hear what you have to say about some of these different offerings. 3 learning objectives, and we are offering 1 hour of certified in public health continuing education credits. The first learning objective is that first you could identify these competencies. They came out in June, but we wanted to make sure to share them in this public forum to the academic public health community. And then next, that you can describe 3 examples of academic public health activities that are working really well to prepare students to work interprofessionally in obesity prevention and control. And then lastly, for you to reflect upon methods, how you might apply these competencies into your own curricular and practice offerings. So with us today, I hope you can see them all on your screen. We have a terrific slate of presenters. I'm going to introduce all the presenters up front so we could roll right through each of their talks. So first, we have Dr. Don Bradley. He's at the Duke University School of Medicine. Among his many roles nationally, he is an associate consulting professor there at Duke. And for us, for this topic today, he was one of the 2 co-chairs who led the Provider Training and Education Work Group of the, and this is a very long title, the Integrated Clinical and Social Systems for the Prevention and Management of Obesity Innovation Collaborative. That's the group that developed these competencies. Next in the program, we have Solvik Cunningham, who's an associate professor at the Emory Rollins School of Public Health. And Solvik's going to be talking with us on data analysis and community partnerships for teaching about obesity. Next is David Saar, who's at the Temple University College of Public Health, where he's an associate dean of research and a professor and director at the Center for Obesity Research and Education, known as CORE. And last, we have Hala Madanat, who is Director and Professor at the San Diego State University Graduate School of Public Health. And I neglected to mention that Dr. Sauer is going to walk us through each of the competencies and give examples of how you might integrate them or how people currently are integrating them into coursework. And then Dr. Madanat is going to speak to some applied practice experiences and curricula in obesity prevention and control. So those are our 4 speakers. Our plan is for Dr. Bradley to speak for about 10 minutes. Doctors Cunningham, Sauer, and Madanat will speak for about 7 minutes each. At the end of each of their presentations, we're going to take, if you have what we call a burning question, we'll take it right then, 1, maybe 2, but we want to keep the momentum going. So if there are no questions, that's fine, we'll go to the end. But that is your opportunity to address a point that might have been of interest to you or you have a question right after each speaker wraps up. So without further ado, Dr. Bradley, the mic is all yours.
Great, thank you, and good afternoon. Thanks for letting me present our collaborative's interprofessional competencies for the prevention and management of obesity. And by the way, that long title we have hyphenated as IXPMO, which doesn't make a lot of sense, but it's a lot easier to say and far quicker. I am going to buzz through the slides that I have on both the process and then an overview of the competencies in order to leave us reasonable time to have some discussion. I do up front want to recognize the Robert Wood Johnson Foundation, which helped to fund this work as we go forward. The competencies arose from work we've been doing at the National Academy of Medicine's Roundtable on Obesity Solution, and in collaboration with the Bipartisan Policy Center, the Alliance for a Healthier Generation, and the American College of Sports Medicine, we pulled together the educationally focused representatives from 24 different health professions organizations that represent a full range of health professions. And when I say health professions, I consider everybody from a social worker to a pharmacist, a dentist, a public health professional. All these are health professionals. Come on. There we go. So our framework really began with Hugh Barr's concept that interprofessional competencies can be categorized into 3 areas. One is common competencies across all of the professions. The second are what we call complementary competencies, which are the ones that are specific to each health profession. And then third is the collaborative competencies, which is really truly a different set of skills in learning to work together as a team with kind of respecting each person's or each profession's skills and expertise. These competencies are not meant to be all-inclusive, in large part because what we hope is that each health profession will take these competencies and integrate them into their own training and educational processes rather than having them be standalone competencies. We then took the Barr's concepts, if you will, and applied them to the Englander health professions competencies, which really breaks things out a little bit more, and then really focused on competencies that are specific to obesity and really did not, again, try to get into each health profession's area of expertise. The process took about 2 years, and we were very clear as much about what the competencies were not. This is not a full curriculum. It's not a certification process. Actually, There are a number of certifications around obesity. We really don't need to do it. And then to really identify a full range of health professions that actually work with patients with obesity. We've now drafted the competencies, and we'll be working on the next phase. The competencies at the highest level, there are 10 competencies. They really kind of break out into core obesity knowledge, interprofessional care, and then patient, and I actually prefer the term person interactions, since not everybody interacts with a stethoscope in their hands. The obesity competencies, again, are broken into several. There are sub-competencies for each one of these high-level competencies, and I would encourage you to go to the site, the website, to really look at the full range. So the first is the framework of obesity as a medical condition. It took the AMA until several years ago to really even classify obesity as a disease, so we're really working on that. The second is the epidemiology and key drivers of the obesity epidemic. The third is disparities and inequities in obesity prevention care. The fourth is interprofessional obesity care itself, and I'll talk a little bit more about that in a second. 5 is to apply skills necessary for the integration, both clinical and community care of obesity. And then finally, to talk about the use of person-centered or patient-centered communication. So that's 6 of the 10, and I wanted to just spend a minute on number 6 because we think this is one of the more important pieces of the competencies. When we talk about overweight, overweight is a description, but obesity or an obese person becomes an identity rather than being, you know, a father, son, a preacher, a physician. They really have kind of lost who they are as an identity, and a person with obesity is more likely to be held accountable for their weight when we know that there's far more that goes into it. Obesity is a disease, and describing a person with obesity focuses attention on the cause. You know, as I've become more attuned to this and I listen to particularly healthcare providers, we talk about patients with breast cancer, not a breast cancer patient. We don't talk about, although it happens a lot, we talk about it should be a child with autism, not an autistic child. So I think the same really does apply to people who have obesity. There we go. The other part of this that's important is the language that we use to describe overweight and an unhealthy weight. This is based on work done by Rebecca Poole and others, really even talking about what language to use when speaking with people with obesity. So things like using obese or increased BMI, severe obesity as opposed to morbid obesity, talking about an unhealthier weight or a healthier weight, and to avoid the word diet. Folks don't do diets anymore. They may improve their nutrition, they may eat better, but folks really have a real reaction to diet. And then physical activity. Many people are willing to participate in physical activity, but activity really, exercise really has someone doing jumping jacks or windmills or something like that, that folks really are not all that interested in doing. So that's those competencies. Then we're going to move on to other obesity competencies, which includes the recognition and mitigation of weight bias and stigma. For those of you familiar with the Harvard IAT test, obesity has as much stigma and bias as both gender and race. And it really does impede the care that people with obesity have. The next one is to implement accommodations specific to people with obesity. Do folks have chairs that they can actually sit in? One example at where I worked prior to coming back to Duke was we had a gym in our office, but we put the treadmills about 6 inches apart with the back side of them facing a big glass window. And needless to say, our employees with obesity weren't terribly fond of getting on a treadmill with their behinds showing out to the main walkway. So again, just thinking through it, gowns that fit, scales that can actually weigh someone who's got, has obesity. We also talk about utilizing evidence-based care or services for people with obesity. And there is now an increasing body of evidence, and then also to provide evidence-based care and services for people with comorbidities, diabetes, hypertension, heart disease, osteoarthritis, and so on. So the next step for us is applying the competencies, both in terms of curricular design, in terms of process improvement, program evaluation, and then as we go along, we will continue to update these. As I've already noted, we use the term patient several times in the competencies that were published in June. I would really move that to person, because I think we're talking about people who not only see a health professional, but those who are not seeing health professionals. And what we expect to get out of this, first, is to really support curricular materials. Again, we're not building an entire curriculum because that's really up to each health professions, but we are working to curate curricular materials so that folks who are interested in incorporating this into their training can do that. We're also talking about faculty development for programs and teaching this. One of the things that I've found, and a lot of my work is around population health, is the residents or the students will be very interested in working on population health or obesity, but the faculty really don't know how to deal with it, and it actually puts them in a pretty foul mood. And then finally, to provide a common language for both clinical and population health experiences. And this is the URL for the competencies. I'd encourage you to go to this and download it and spend a little bit of time with it. And with that, I will stop.
Don, thank you very much. That was such a clear overview of the competencies. We don't have any questions now in the box, so we're going to keep the momentum going. But those of you who do have questions or comments, go ahead and type it into the chat box, and we could address them as they come. So next up, Dr. Cunningham.
Thank you. So I'd like to share some ideas around teaching about obesity in terms of classroom work as well as working with community partners. And I'm drawing here largely on some of the projects and the teaching that I've been doing at the Rollins School of Public Health. So this is primarily with MPH students, so not exclusively. We do get PhD students or undergraduates who are also often interested in obesity and other chronic disease who will join in these activities. So very broadly speaking, we can think about teaching about obesity in the context of classroom-based learning, and that can include substantive courses focused on obesity, as well as methodological courses that incorporate obesity as a possible area of research. And then on the other hand, especially for Masters of Public Health students, there is a lot of interest and opportunity for community-based learning and engagement, and this includes both research as well as practice with NGO partners. So let's talk a little bit about course-based learning. Just to start with challenges, I'd say that obesity is an area of research that, an area of teaching and coursework that gets mixed interest for students. There are some years when there's a lot of interest. There are others in which there's very little. So there are ebbs and flows there in the level of interest. Another interesting thing that I often find in terms of challenges in teaching about obesity is that there perhaps building on some of the previous discussion, there is perhaps a view among many students of disease as a common sense solution. Like, we all know what causes obesity, and we all know how everybody could eliminate obesity. So an important first step, I think, is thinking about those prejudices and the expectations that people have about obesity and about people with obesity. Some of the strategies that I use in that respect might include, for example, I'll have students before they even come to the course doing a news search or a social media search to see what kind of information, news or reactions they find in the public domain relating to obesity. I often will also do a quiz, especially focused on the myths around obesity, to get people to think a little bit about how they're coming to the study of this condition. I think it's also important to include multidisciplinary perspectives from the literature. Obesity is an area of work that has included epidemiologists, nutritionists, sociologists. So there are many perspectives here that we can draw on, and there are often controversies, and I find that students enjoy engaging with the heated debates that we can find in the literature, and engaging in debates in the classroom also around the different perspectives that the literature brings to understanding obesity. I also think that it's very important for students to have firsthand experience with analysis. Very often in the context of obesity, you're not going to there'll be these common sense expectations about, well, of course, people with obesity are ones who drink a lot of sugar-sweetened beverages or who eat a lot, or these expectations that people come to the table with. And it's very interesting, I think, for students to try out the research themselves, try to look at some data sets and see, are those expectations really being fulfilled once we work with real data and once we see the intricacies of human health and of human behavior firsthand through research. And this research can involve quantitative or qualitative data sets. Often, especially in the context of a one semester course, I'll prepare sort of a pre-cleaned, easy to use data set in the software that students are familiar with, so that they can easily access the variables, easily access the data. For qualitative tests, for students interested in qualitative data sets, I think there's also a lot of interesting potential in the area of obesity in terms of looking at texts and narratives, advertisements. There's a lot out there that would lend itself both to quantitative and to qualitative research. Finally, for those students who are interested in the methodological perspectives, I offer opportunities to develop data instruments for collection of quantitative, qualitative, or textual data having to do with obesity. I've listed here just a few quantitative data sets that I think are particularly useful in teaching students. These are national representative data sets, which are easily available and have public use versions. For research on childhood obesity, two data sets that I like a lot are the Early Childhood Longitudinal Study Kindergarten Cohort and the National Longitudinal Study of Adolescent Health. These both have directly measured anthropometrics at multiple points in time, as well as a lot of contextual variables, family, neighborhood, school, pieces of information that would be relevant to understanding obesity. With respect to to obesity in adults. Two data sets that are commonly used are the National Health Interview Survey and the BRFSS. Both of these have self-reported anthropometric measurements, so that's a limitation, but still very useful and widely used. And finally, in terms of international levels and trends, the demographic and health surveys from many countries around the world, especially poorer countries, have information on height and weight and sometimes other anthropometric measurements. So these are some easy places for students to find real data that they can use to explore some of the questions that they have about obesity. The second component of teaching that I wanted to touch on is the community-based learning. And there are many structures, especially in the context of schools and programs of public health, that allow students opportunities for applied work in obesity. I mentioned here practica, which are often MPH requirements, rotations, which are often requirements for PhD students, theses and dissertations, as well as volunteer work or internships. So one of the challenges to think about is how do you make these matches? How do you find organizations? How do you find opportunities for students? For me, I've often built on my ongoing relationships. For example, many of us are on boards or are associated with NGOs that would be very excited to have students help them in various capacities. Many universities may also have offices that are focused on creating university and community partnerships, and those often will help match students with opportunities in the community. I'll give you some examples of work that students could do with NGOs based on the experiences of some of the students I've worked with. One possibility is program development. For example, I've had a student work on developing a curriculum for teaching about fruits and vegetables and physical activity to English language learners. Students can engage in program augmentation. So if an organization already has a program going on, they can add, enhance it, broaden it. For example, I've had a student who has worked, who has expanded an existing diabetes prevention program to Arabic speakers, where the NGOs that were initially offering the program did not have the possibility to for those language translations. Organizations are often interested in evaluations. Very often they'll have very exciting obesity prevention programs, but don't have the capacity or the know-how or the time to actually evaluate to what extent are those programs making a difference. And Masters of Public Health as well as PhD students often have the skills and are interested in practicing the skills of program evaluation. And finally, students can be involved in proposal development. For example, working with a nonprofit partner to identify some of the strengths that they can enhance and design into a study that they can bring to a funder in order to expand their services. Thanks.
Thank you, Dr. Cunningham. That was really interesting, those examples of how you use data in research and community activities with your students to teach obesity prevention and control. Thank you very much. Without any questions currently in the chat box, we will move right on to presenter number 3. Dr. Sorer, it's all yours.
Thanks, Liz. I appreciate that. So Dr. Bradley teed this up very nicely for me. What I'm going to do in the few minutes that I have is do a little bit of a deeper dive into the competencies and give some more specific examples of places where here at Temple we're already using or in our coursework already providing these opportunities for our students, as well as some ideas of other places that we could do this in the future. And one of the things that I find really interesting about these competencies is that as somebody who's both an obesity researcher as well as somebody who's been a clinician providing clinical care for weight management for the last 20 years, it's interesting to more or less go back to the basics and remind ourselves what are the big messages that we want to be communicating to students and ultimately to patients about issues around weight management. Because I think sometimes when we're deep into our practices and our research, we sometimes forget what some of those basic tenets are. And I think one of the great strengths of these competencies is, in fact, really going ahead and reminding us what those are. So the bullet points I really want to highlight are the ones that I put in red here. One of the things that I recall when I started work in this area, and I'm sure Dr. Bradley and others recall as well, is that we really had to push very hard to get physicians, let alone other providers, to even calculate a BMI, let alone a waist circumference. And now, because of things like electronic medical records, we know that BMIs are much more readily accessible to us. Waist circumferences, BMIs are obviously are imperfect measures, but they still have their strengths in a number of ways. Many people would argue that waist circumference is actually a much more valid measure of adiposity and health risk, but for a variety of different reasons can be challenging to obtain in different settings. But I think a great thing to communicate to our students is that a discussion and a measurement of BMI and waist circumference is a great entry point to beginning to think about a discussion around issues of obesity and its comorbidities. A couple of things that I think is very inherent in all of our schools and colleges of public health is this focus on the multidisciplinary contribution to the diseases that we study and that we teach our students about. And obesity, without question, checks all of those boxes, because we know that there are all of these influences listed here and countless others that don't fit on the slide that really impact what happens to a person's weight, let alone their ability to successfully control their weight. And so I think inherent in many of our programs of education are some of these tenets of recognizing that the diseases we face are truly multifactorial in nature. And then clearly under this first competency, there's an emphasis on integrating both clinical and community systems as partners. And one of the things I've really enjoyed about my work coming to the College of Public Health at Temple, after being in a medical school environment for 20 years, is that it's reminded me to refocus my work on the community systems and the role that they play in whether it be the development of obesity, the maintenance of unhealthy weight and comorbidities, or the opportunities they present to, in fact, deliver interventions that can help people. The second part of the competency number 2 focuses on epidemiology, and obviously that's one of the core tenets of the work that goes on in all of our colleges. And as Dr. Cunningham alluded to, there are a number of different large data sets that have public accessibility to them that would provide a great opportunity for our students to play and learn about mining big data sets and asking very relevant questions. Moving on to the third competency. One of the phrases that I find myself using a lot in my work over the last few years is something called the psychosocial burden of obesity. Now, many of you may know that there's always been a controversy in the past of whether obesity is a psychiatric condition, a medical condition, and as Dr. Bradley alluded to, the AMA several years ago reached a consensus that it is a medical condition. It's never been recognized as a psychiatric disorder. But we know that obesity and its comorbidities come with a significant psychosocial burden, and that sometimes these issues also run parallel to other challenges that our study participants, our patients and communities face with regards to inequities, as well as elements of access to care, that many of the populations that we work with simply do not have access to care, even when major health systems, hospital settings, and community groups are making interventions and programs as readily available as possible. With regard to the fourth tenet, this is really the emphasis of interprofessional education. And as somebody who's trained as a clinical psychologist, but has spent a lot of time working with physicians and dietitians and exercise physiologists, this is really a sweet spot for me, because I truly believe that the only way we're going to have any effect in moving the needle against the chronic invasive disease like obesity is really going at it with a multidisciplinary and multi-professional approach. And I think the sooner that we can mentor our students and think about our training programs as ways to bring our professions together to look at a disease, to put the disease in the middle of the room or in the middle of a patient group or a group of students and say, given your multidisciplinary background, how would you help a patient address these issues with his or her weight? I think is a great way for our students to learn. And we try to do that regularly with our therapeutic professions, so OT, PT, RT, as well as some of our social and behavioral sciences students and faculty as well. Moving on to number 5, again, emphasizing this role of the integrated clinical community health care plan. How do we train the next generation of health professionals to not only be able to work with an individual patient in front of his or her, but help that individual or help that community group find and identify other resources and community organizations that can help foster successful weight management in the long term. Patient-centered communication, and this begins to dovetail a little bit with what Dr. Bradley emphasized in his remarks, and I'm not going to spend as much time with it, but really the importance of using patient-centered communication. And I really like his emphasis on the use of the term person-centered communication. Having been in a medical environment, I'm used to patient-centered communication, but I think for our environments in particular in public health, person-centered probably resonates with people to a much greater extent. So I would very much endorse the use of that phrase, but also the importance of talking about patients with obesity, patients with overweight, as opposed to saying an obese person, an obese man, or obese woman. And as Dr. Bradley also alluded to, the pervasive role of weight bias and weight stigma. For many of us who have worked in this area for a long time, we've long known that individuals who struggle with obesity, let alone those who are extremely obese, are subjected to bias and stigma as they walk throughout the minutes of their days. Unfortunately, it is still very socially acceptable in many corners of our country to treat people differently, to judge them differently based on their weight, even with the scope of the problem. And in recent years, as many of you know, the work of Rebecca Poole and other colleagues around the country have really illustrated that not only does this contribute to that psychosocial burden that I referred to, but it also can have a consequence on people's overall physical health, as well as their engagement in weight management programs. And that perhaps all of us who work with patients around issues of weight need to really think about and consider this issue and talk with our patients, our study participants, and our community groups about the way that weight bias impacts their decisions. And Dr. Bradley's example of the treadmills is a very elegant one, in which while we may think that people want to be in front of a big window when they exercise, we may not be thinking that there might be untoward consequences to be on a treadmill in front of a window where other people can see it. Now, issues of accommodation and safety, I think, are very important, but I was really challenged to find how they really lend themselves all that well to public health programs and the training that we provide. When we work in medical center settings, we're always thinking about, do we have chairs that can accommodate people with extreme obesity? Are we being mindful and sensitive to the physical spaces where those individuals are walking and interacting with our system? And by all means, we should provide that education and training to our students so that they're mindful of those issues. But it can be, I think this is one issue that we need to all give a little bit more thought to about how we apply it to our educational programs. And then one issue that I really want to emphasize here is the role of credible information. One of the things I think we're all challenged by when we think about issues around weight management is there's an awful lot of noise in our day-to-day world about you should try this diet, you should try this approach, you should eat this and not that. And unfortunately, so much of that evidence, so much of those recommendations is not evidence-based. In fact, I saw a study recently that suggested that well over 90% of the smartphone and Android apps that are out there to help people manage their weight have no evidence basis behind them whatsoever. So I think it's important that all of us communicate credible information based on the state-of-the-art evidence to our patients and the individuals that we interact with. And then it kind of it illustrates this point of shared decision making. So how can we be flexible in our thinking with patients to realize that the interventions and the strategies for success that we deliver may not work well for each individual patient? And how can we adapt and tailor them, remain evidence-based, but at the same time make sure that we're appreciating and respecting the unique set of circumstances and challenges that an individual may be bringing to those interactions. And then finally, I'll end with this point. which is really helping identify people who are struggling with their weight and the comorbidities and making recommendations and appropriate recommendations for assessment and treatment. And this is something we work with healthcare providers all the time, in saying that even if you don't feel comfortable or confident in treating obesity, you can play an important role in directing patients, people in your community, to reputable evidence-based programs to help those individuals be successful with weight control. And those are some of the messages that we try to communicate to our students, both in the classroom as well as in some of their clinical practicum experiences as well.
Thank you so much, Dr. Sara. That was a really excellent elucidation of the entire competency set, and with your inclusion of the various approaches to making sure our students acquire these abilities they could practice in the field. Moving right along to our fourth and final presenter, Dr. Madanat, the floor is all yours.
Thank you. So what I'm going to do today is give you some examples from the work that is happening in the Graduate School of Public Health at San Diego State. And I thought that to set the stage to why we have a lot of work and exposure for obesity prevention work in the school, wanted to give you some of the background information on us. So let me see if I, for some reason, here we go. So the GSPH is resources and capacity in relation to obesity. So we have a number of faculty with expertise in a multi-level community-based intervention to reduce health disparities, and have had for their careers for 30 years or so focused on obesity prevention, and have brought in a number of more junior faculty to work with them in this area. So we have a strong team of people doing obesity prevention. We're also in San Diego, located in a border region, so we have binational expertise that allows us to provide experiences to students that are different than maybe in other areas. And I'll give you examples of that work across border. And we've had experience in the community. So our partnership, as previous speakers have alluded to, is building this capacity to work with the community can be sometimes very difficult, but we've been in this community with this work in obesity for the last 25 years, and so the partnership are extremely strong. So we've had County Health and Human Services Agency, federally qualified health centers we work with, community-based organizations, faith-based organization, and then we've worked within the schools and recreation centers. So this is particularly important within one of our centers of research, which is our Institute for Behavioral and Community Health. And in the IBACH, as we call it, the resources that our students have access to are the following. We have about 28 investigators, and that the importance of that comes from the fact that these are not just public health, even though it's a public health research institute. We have marketing faculty, sociology, health promotion, public health, nutrition, health services researcher, engineers, and communication faculty working with the students. So the example I can give you specifically in relation to how interdisciplinary this becomes for our students is that we are, in one of our current studies, we're working with grocery stores on identifying the parent-child relationship in purchase. So, for example, are the parents if they have their children with them and the child comes in and says, I really want this chips, I want this, and keep repeating, are the parents succumbing to it eventually in buying the things they don't really intend to, that may not be the best choices from a food perspective, from a diet perspective? And so we have an eye tracking intervention where we really track what the children are doing, what the parents are doing, what they're looking at. But then also we have observational communication for the parent-child interaction. And those then are brought into the students' experiences to really teach them about how do you modify this outcome around healthy eating, for example, to incorporate more other disciplines. So the technology around eye tracking and the communication discipline. So we work with our colleagues from speech, language, and hearing sciences on that. And so within that institute, so then beyond the faculty, the investigators, we also have for our undergraduate students exposure to doctoral students, postdocs, and MPH students, and obviously for MPH students, exposure to those. And so it gives them experiences that go beyond the classroom. But I also wanted to point out how the integration of this infrastructure into the actual student MPH practicum specifically, obviously our PhD students, similar to the example given before, was our PhD students do rotations, our undergraduate comes in there as a research assistant, but the bulk of this becomes focused on our MPH students, and it's integrated clearly into their practicum. So they come into an intervention, and the example I'm going to give you today is from our San Diego Prevention Research Center that was funded by CDC. Our main intervention from that Prevention Research Center was a physical activity intervention that was community-based. We worked to train community health workers, promotoras, to deliver this free physical activity classes across the entire community. We had 47 weekly classes that were free. We had about 2,500 community residents that attended it. And so the students in that particular intervention were involved from everything from intervention design to developing of the training materials for the community health workers, to the coordinators that saw them, to the actual materials that were in the healthy living component. So beyond the physical activity, there was a healthy living classes. So developing all those materials. This large intervention had a community advisory board and a CAB, and so for that the students were also involved in doing the community presentation about the research and the intervention. They learned how to run meetings like that, which I know is not the obesity component, but is an important competency within the MPH, and using the obesity prevention as the way to do this. They learned evaluation. So, and this is everything from specific outcomes around BMI measurement, physical activity, and specifically observation on the intensity of physical activity intervention. So in the prevention world, really involved in how do you assess how this is occurring. But then they took all of that, and in our last year of the Prevention Research Center, took our intervention and turned it into disseminated it into a toolkit. So they were involved in the video development, in the materials development, and all of that to put together. And of course, as again was mentioned, we have lots of access to data as a result. So students were involved in this particular intervention for thesis, for data analysis, for writing. And the writing went to a combination of things. So the professional writing, but also writing of newsletters, op-eds, and really influencing the way people looked at obesity prevention within the Latino community where our work was based. So the community engagement is really important part of it. And then the other part of it is beyond the practicum is the integration of this the prevention work into our curriculum. So primarily, we want exposure to, we want all of our students to have exposure to these obesity prevention and control competencies. So the incorporation was largely done through required courses. So integrating the examples from our own work into, for example, theory. So in theory class for our MPH students, they take they explore socio-ecological model, and then we take them through one of our interventions demonstration grant on this from multi-level intervention, going from the individual to the family to the community to the policy level. And this included everything from clinic, restaurants. So integrating the curriculum with this obesity prevention outside of dedicated courses, which we also do. So this is infusing our EPI classes, infusing our theory classes, infusing our all of our classes as much with this obesity prevention content. And then dedicated electives. So we've had a number of those and many popular ones. The first one I list here, the Obesity on the Border, is one that's being tested for the first time this spring, and I'm really excited about it because it refers to my what I was mentioning about the importance of our location on the border and our partnership with Mexico. So we are, the course we're developing is obesity. It's called Obesity on the Border, and it's going to be taught on our partner institution's campus on the UABC Universidad Autónoma de Baja California. Our faculty and our students travel weekly there. The class is taught there, combined between our US faculty, our Mexican partners, and really looking at the approaches to obesity prevention and how they're different in these different settings. It's really important, especially as New York Times yesterday had a great article on the impact of NAFTA on Mexico's obesity, and having the students have a more global perspective on what obesity prevention means outside of the context of the US. And they've done some phenomenal work in Mexico on things like reducing sugar-sweetened beverages in schools, for example. Lots of policies that we haven't applied in the US. So this binational experience allows students to really understand it from a broader perspective. And then we've been teaching a course on childhood obesity with our county health and human services agency support. So our students get the content in the classroom, but then do an application with the county program on childhood obesity prevention, where they develop materials, they actually go out with the schools, they help develop policies within school systems to improve the access for healthy food and increase physical activity and reduce sedentary times. So, and then we have other ones like an intuitive eating course, so it becomes much more specific to a particular approach for obesity prevention. But these are really popular courses, and while they're electives, given that we infuse the curriculum with so much obesity prevention, I think we get so much interest in these dedicated electives as well. They're very popular for our students. But one of the things I wanted to point out, since this is really about also the competencies, is that we've been doing this for 20 years prior to the competencies. And what we're hoping to do in the next year is to use the competencies that have been developed and map them onto the work that we've already been doing into classes and see where we're actually giving very specific competency-oriented competencies and skills to our students in these dedicated electives and in the courses that are required of our students. The competencies are a really nice framework, add a nice framework to the work we've been doing, and we've been really excited about the fact that they've been released. So thank you for everybody who worked on those. And that was it on my end.
Dr. Madanat, thank you. That was a really nice tying together of a lot of the prior comments and linking it to both your practice and your curricular examples. So thank you very much. We're moving now to, we have a little less time than we thought, about 7 minutes for the Q&A discussion comment portion of the webinar. Go ahead and type into the chat box if you have anything you'd like to say. We do have a question already. Here it is, and if all of the speakers, please, if you're still able, great. Don, you came back. You want to go ahead and put your webcams back on. First question is, do you think that obesity is a problem physicians or insurance companies must solve? Who would like to take that one?
So, having worked in the payer world for over 25 years, I can tell you that the insurance companies understand that it is a problem. We had done some studies when I was chief medical officer at Blue Cross Blue Shield of North Carolina, and people who are overweight cost about 16% more than people of normal weight, and people who have obesity cost about 32% more than folks of normal weight. So we understand it as a problem. I think the issues for payers is that nobody trusts them. You know, there's a lot of other players. We can support a lot of things. We try to do a lot of things. We offered health benefits. For instance, one of the things that we did was to actually provide coverage for physician assessment of obesity. up to 4 visits a year, and also to cover nutritional visits. We had a tougher time credentialing full programs because the bright line gets a little bit tough. So let me stop there. And did it answer the question?
Thank you, Don. Would anyone else like to comment? That was a very thorough answer. Okay, move on. Here's a longer question. Has anyone heard of community courses that teach young people how to cook healthy food with what they can afford, thinking that most home ec classes have been abolished and these young folks can't cook healthy or how to buy healthy?
So we have a couple of programs here at Temple where we're actually doing that, but they're happening more at the grassroots level, where we've got faculty members who have come up with a novel idea with a community partner and have started to implement them. And I optimistically think that we're probably just a few years away from seeing some of those things really blossom and beginning to perhaps have an evidence base to show that they can actually be effective. I think it's a phenomenal idea. I completely agree with the point that we've probably gotten away in elementary school education, junior high and high school education about teaching those basics, and it would be great to be able to get back to them. And I would love to see them go forward because I think there's great potential there.
And I'm going to say we're in the same boat. There's pretty much exactly as David mentioned, we really have the same faculty who've worked with community partners, developed these courses. They're largely housed in our federally qualified health center community outreach programs, where they're really linking with the community to do these demonstrations. They've built kitchens actually on site, some of them, to bring in the community members, the young, and all ages, to be honest. They've gone really young all the way to adults to do these demonstrations and show them how to go. And they actually added a field trip to the grocery store to talk about this concept of the financial aspect of how to identify what to buy and how reasonable it can be to cook healthy, for example.
And the other, probably the most remarkable example of this is at Tulane, where they actually teach medical students how to cook as a part of their curriculum, and they also open up that center to the community. So I think academic health centers, schools of public health have a great opportunity to work in that kind of area. And I would agree, the grocery store tours, I know our county health department works on that and also teaches cooking classes.
A few additional comments on that question. Thank you for that, Don and Colin and David. Robert Lustig has a cookbook meant for teens to use for cooking food that is low in sugar and healthy. So that's Robert Lustig, L-U-S-T-I-G's cookbook. Sounds kind of interesting. And another comment, the YMCA has many programs around the country, such as these. So another group to check out. Well, it looks like that is about all that we have time-wise. I wish we did have more time. And I want to thank all of today's presenters for your time, your preparation, and your willingness to share your expertise, your insights, your experiences with ASPPH members and our community and academic partners. It was terrific. And this webinar will be archived for subsequent viewing. And I'm going to just point out to you all on the ASPPH website at the beginning of the webinar, we pointed out where the competencies are housed with the Bipartisan Policy Center. But on our own website, if you go to our main page, and you pull down the Teach and Research tab from the top and go to Faculty Resources, and you'll see there under Educational Models and Reports, then you'll flow down to a page, and since these are workforce competencies, go down to the workforce section, you'll see we posted the competencies there to make things a little easier for you to find for referencing. And Dr. Mott, I like your comment to go back to how you said you're going to be mapping these competencies. I think we may have another webinar down the road. So we'll check in with you in a year or so and see if you might be ready to share, and see what else we might be able to illuminate regarding advancements, and if there are any early adopters out there to hear from your experiences. So again, thank you very much, and Sarah Winder is going to wrap up with some closing comments.
Yes, thank you again to all of our presenters. And as Liz noted, this webinar has been recorded and it will be available on the event page in the near future. All who registered for the webinar will receive an email when the recording and the slides have been posted. And there will be a short evaluation that will pop up when you close out, and we would really appreciate your feedback. Additionally, there are a few other webinars coming up in January, and we encourage you to look into those on the event pages that are linked here, and hopefully register. And lastly, the 2018 ASPPH annual meeting and the Undergraduate Public Health and Global Health Education Summit will be in early March, and registration is now open. Hope to see many of you there. Thank you all so much.
Thank you.
Thanks, everyone.